they are at the risk of other physical problems such as falls. You see a patient that is having delirium because oftentimes you see them, maybe they want to transfer from bed to chair, or they want to get out from their bed because they are not aware. They may not be able to judge the height of the bed to the floor, and that can result or increase their risk of fall. So you could see that delirium again leading to another complex problem, which may be that can worsen their underlying diagnosis of stroke. Again, their perception may be affected. Again, still looking at delirium, you see delirium develops over a short period of time, usually hours to days, and is considered a medical emergency. It is often missed or misdiagnosed, and that also underscores why we are looking at this, so that we can pick this up. Although there are other conditions that can precipitate delirium, it's not just associated with neurological condition. Even prolonged stay in a hospital can increase some patients' risk of delirium, and infections or even acute surgery, maybe post-surgery, many may present with delirium afterwards. So delirium is often triggered by acute illness, surgery, injuries, adverse effect to medication, and is reversible if its underlying cause is treated. So about 30 to 40% of all delirium cases are preventable if simple person-centered intervention are engaged. And that's one of the things that makes tonight teaching very, very, very important. Now, why do we need to screen for delirium? Delirium is a serious condition that is associated with increased mortality, which often go under-recognized. Delirium is also associated with an independent. Delirium is associated with, is associated and is an independent predictor of multiple adverse outcomes. Increased length of stay, higher risk of injuries like falls, increased risk of institutionalization and post-discharge, and decrease in cognition and functioning. So you can look at delirium, just delirium alone, having all this problem and all this risk attached to it. So you imagine when the patient is having neurological condition and delirium is presented with delirium, and maybe because of maybe we are not paying adequate attention to it, we're just concentrating on the physical component, we could see the harm that omission on our part can wrought in the life of the patient. So now, see, talking about delirium. Now, these are other potential causes of delirium when patient is in pain, infection, nutrition in terms of when the patient is having some kind of essential vitamin deficit, maybe vitamin B12, folic acid, folate. All these can also lead to delirium. The patient with constipation may be having problem with delirium. Dehydration has been linked seriously with delirium. So that's one of the things that we as therapists will always encourage when we have a patient on admission, encourage that they hydrate very well. And there are some medication that tend to alter the cognition of the patient and environment. Also, the hospital environment, also, as I said earlier on, can be one of the things that can increase their risk. Now, having seen delirium as one of the cognitive issues that may come after stroke, what are the screening tools that have been found to be very useful in assessing these cognitive elements after stroke? Excuse me, please. Get me that water, please. Sorry. Sorry, thank you. Drop it there for me. So there is there are some standardized assessment. There are actually more than this, but for want of time, just brought the one that are that we often use stemming from my professional practice. So the 480, which is specific to delirium, is not specific to any profession. The doctors use it, the nurses use it, the OTs, the PTs, they use it, and it's actually a quick screen that tends to establish if the patient has delirium, and the score of the patient can indicate that there will be need for more assessment, and it can be used to predict that the patient will definitely have other complex cognitive deficit. The other one is the generalized anxiety disorder, the GAD-7, which is used to screen for Anxiety, the next one is the PHQ-9, which is a patient health questionnaire and can also be used to screen for depression. Now, looking at this more in-depthly, this is the 480 screening for delirium. So it's a standardized assessment and it's got different components such as alertness, the uh, AMT for component, the attention component, and the acute change for or fluctuating cause. So these are just what questions. It's like a structured interview question that you're going to be asking the patient, okay, and couple with your clinical observation that you have to engage. So in the alertness, so you are actually looking at if the patient is having a kind of marked drowsiness, so you can judge the level of alertness of the patient, and depending on how the patient is in terms of physical alertness, or if the patient is agitated or hyperactive, so that will determine, or the patient is falling asleep. Maybe you go to the patient bedside, haven't introduced yourself, and you gotten consent to treat the patient. The patient is struggling to keep awake, falling asleep, and you could see that even when the patient is asleep, it's difficult to arouse him with the gentle voice, or you need to touch the patient. So all this will determine what to score the patient. So it's very straightforward and self-explanatory. So for instance, if the patient is normal under that segment, the patient scores 0. And if it's mild sleepiness, the patient less than 10 seconds after waking the patient, then you still give 0. But when the patient is clearly abnormal, maybe because the patient appears to be very drowsy, struggling to keep awake, and becoming, that is unable to maintain alertness, you score 4. So the other aspect, which is the AMT, so you see, you ask the patient about their age, their date of birth, the place where they are, and the current year. So if the patient response has no mistakes, 0 is scored, and 1 mistake is 1, 2 or more mistakes in that segment will result to a scoring of 2. And the next component is attention aspect, which is you ask the patient, for instance, you ask the patient, please tell me the month of the year in backward order. I'm starting from December. Sometimes we have to kind of give the patient a clue or prompt them by just, maybe when you say December, you expect them to complete it. So, and when you see that the patient is in trying to call the months in backward order achieves about 7 months or more correctly, that is considered to be normal in the normal order or sequence. When the patient starts but scores less than 7 months correctly or refuses to start, 1 is called unable to even respond to you because the patient is too unwell or is too drowsy, or the patient is continuously inattentive, cannot even sustain adequate attention to engage in that task, you score 2. So the last but not the least is how the patient has had kind of fluctuation in their illness. So evidence of significant change or fluctuation in their level of alertness, cognition, other mental function will be judged, and these will be scored. Maximum score is 4, and when you don't discover any problem in that regard, is 0. So everything put together will be scored, and if the patient total score is 4 or above, so it tells you that there is possible delirium, a plus, and there can be in addition or without other cognitive impairment. A score of 1 to 3 tells you there is possible cognition impairment, and a score of 0, delirium or severe cognitive impairment are unlikely to be present. So this is a very straightforward assessment that we can do can engage for our patient to screen out if they've got delirium. And it can also signal other underlying or other the presence of other cognitive impairment. Now, coming to the GAD-7, which is specific to anxiety. So it's also a very straightforward question. There's 7 items kind of questionnaire that the patient, or assessment that the patient, all you need to do is just to ask the patient all these questions in relation to what has happened in the last 2 weeks leading or before the diagnosis or the point the patient is presenting the patient has been diagnosed of that condition. So the question will read that over the last 2 weeks, how often have you been bothered by any of the following? That is feeling nervous, anxious, or at the edge. So the patient response will be either not at all, several days, more than half of the days, nearly every day. So depending on what the patient responds to, and in each of these questions, you score the maximum for each question is 3, and the least the patient can have is 0. So you, at the end of the day, the total score is rated over 21, and the higher the score of the patient, the more severe the patient. So a score that is less than 4 will mean that that is normal, because there are still some of this presentation that normal, in quotes, what we define to be normal, people will present with that will not necessarily make them to be having anxiety. Sometimes even in a normal condition, maybe because of the thought or expectation or hope of something, anticipation of certain event or occurrences, we may be nervous or anxious, and that does not mean that we are having anxiety as an established diagnosis. So a score less than 4 can still be considered to be normal. So this is how this assessment is being engaged. And that leads us to the next one, which is the PHQ-9. The PHQ-9 is specific to depression. So the same way you ask the question for anxiety is the same way you ask this question for for depression too. So when the patient tells you that, for instance, the last question on this scale is thoughts that you will be better off dead or hurting yourself. When the patient responds to this, for instance, let's say more than half of the day or nearly every day or several days, it signals the fact you shouldn't just leave it there. So that means the patient is actually having suicidal ideation and other more specific psychological and psychiatric intervention will have to be recommended for this patient, because if that patient is left on the ward, and he has access even to the medication that he needs to do based on the recommended dosage in an attempt to carry out the thoughts of being better off dead, the patient may abuse that medication, and it may be a case of negligence on our part, because your assessment had actually suggested that this patient has been having death wishes and suicidal ideation. So just waiting for an opportunity to action it, and just because maybe we didn't pay attention to the relevance of this assessment, can actually result into that level of fatality in our patient, which is quite avoidable if only we pay attention to this. So this tells us about the relevance and the significance of this assessment, not just for their treatment in the long run, but it can also help us to take into very swift and prompt in preventing some of this fatality that may result from their psychological or cognitive mental health problem that is happening alongside with their stroke. Now, coming to the other component of the presentation, which is cognition. So what is cognition? Cognition has to do with what the mental process that enables us what? To attend, to recognize, to learn, to remember, to plan, to problem solve, to monitor, to judge. Now, if you look at cognition, if you take cognition out, cognitive function or our cognitive ability, if you take it out, we are just what? We are left with nothing, because the cognition is what makes all what we do in the physical component to be meaningful and to be purposeful. If cognition is taken out of, so the voluntary control, purposeful movement, and everything becomes useless, because the mind that underlines those actions is already taken out of it. So that tells us cognition is an essential and integral part of our normal functioning in our day-to-day life. So as I said before, it's all about attending, recognizing, learning, remembering, planning, problem solving, monitoring, and judgment. And judgment is very important to everything we do in our day-to-day life. So why is it important for us to understand cognition? Now, it may interest us to know that WHO recommends that cognitive problem interferes with rehabilitation, and that interferes with should be dealt with. Most of the rehabilitation therapies dealing with neurological problems will come across cognitive deficits. So that's why good knowledge of this domain is very, very important, because oftentimes as rehabilitation therapists, our attention is actually drawn to remediating problem in the physical domain. You want to increase the range of motion, you want to improve the muscle strength, you want to facilitate the voluntary control, you want to normalize the muscle tone, you want to ensure that the sensory registration and interpretation is actually adequate and all that. That will be overwhelmed with that, leaving cognition, and cognition can actually mar whatsoever progress that will register in those physical domain. So cognitive difficulties have a major impact on quality of life. Cognitive deficits can be rehabilitated, and that is the beauty of what we are learning tonight. Now, looking at cognition as a component, it's like what? A pyramid which has different level and different steps. At the very basic, at the very foundation of every cognitive function is senses. That is our sense of what our sense organs. So our sense of smell, sense of vision, sense of touch, sense of hearing, because these are the channels in which we get information from the environment. And when we are able to get this information, that's when we will think of what processing it to make a kind of what we call adaptive response or normal response in with respect to the demand of the task that we have to engage in per time. So at the very basic level of it is senses, and the next level is attention, being able to attend, to pay attention to any form of information that is coming from the environment. The next is visual processing. Next is information processing. Memory is the last but one stage, and at the very top of it is executive function, our reasoning, our judgment, our problem solving, our ability to follow instruction. All these are actually reside at the peak of the hierarchy. So, and you could see that a problem at this level, at any level of this hierarchy, can mar our cognitive ability, which will definitely affect our performance in our activities of daily living or in our social engagement. Now, let's unpack them one after the other, starting with, I've talked about what the senses are, and it's very basic, we can relate with that. Coming to attention. Attention has also other sub-component or different types, as it were. We have what is called focus attention, sustained attention, selective attention, alternating attention, and divided attention. So when we talk about focus attention, this relates to momentarily hooking or on a stimuli, usually not a problem once a patient is out of coma. For instance, a patient that has stroke may come down, and their level of consciousness may be affected, okay, and their ability to focus. That's when we will do our assessment of their glaucoma scale, depending on how they respond. We say, oh, this patient is comatose. He cannot even focus on maybe what is being said, or focus on tactile stimuli to be able to make appropriate response. Or for those of us that are occupational therapists, when we are engaging our Rankor's loss amigos scale, which is a more specific assessment of cognition, we see that, oh, the patient that is scoring low on that is unable to do what? To focus on any of these stimuli. So that's at the very, very, very basic level of attention. The next is sustained attention, ability to maintain focus attention over a period of time. For instance, now, as I'm speaking, I believe all attention is on the auditory information, the information that is coming to every one of us. So we are paying attention, trying to make sense out of it. So that will be within the purview of sustained attention. The next level of attention is what is called selective attention, ability to ignore irrelevant distraction and select stimuli. For instance, as I'm speaking now, it's possible in our respective homes or wherever we are listening to, there may be other things that are going on around us, maybe children walking around, some people discussing, or music being played at the background. But being able to tune our mind to ignore those information at the background and concentrating on the one on the foreground, that is selective attention without getting distracted. Alternating attention, that relates to ability to switch the focus of attention between different stimuli in controlled and smooth and rapid manner. So, for instance, you are typing on your phone at the same time you are typing on your phone at the same time you're having discussion with somebody, okay? And divided attention is what? Ability to split sustained attention between two or more tasks. Okay, you are driving on the road, you are discussing at the same time, you are concentrating on the road, at the same time, you are engaging in conversation. And as you are focusing on the road ahead, maybe for those of us that are using maybe Google Map, you have it placed on your phone on the dashboard. You're also looking at that. So your concentration is on the driving train, trying to navigate, on the road, not maybe driving to other people's path. At the same time, you are trying to look at the direction you have to follow on, connecting with maybe those that are using SatNav or other app, or at the same time, you are speaking with someone that is sitting beside you. So being able to do all this, using that word, literally in a tasking fashion, that we amount to divided attention. So but the very basic level of it is the focus attention, and any of this may be affected in patients with neurological deficit. Now, coming to the next component in the hierarchy of cognition, we've dealt with the senses, we've dealt with attention, we're looking at visual processing. Now, this also has its own sub components, okay? At the very basic level of it, it also has its own pyramid. Is you have the oculomotor skill, that is how the ocular movement, how the different muscles of our eyes, how they work together in a conjugate manner, okay? And all these we play a very vital role in visual processing. For instance, for a patient that have neurological deficit, for those of us that engage in assessment and neurological assessment, we do a lot of specific assessment. Maybe you want to look at how the different muscles have been affected, or how the eyes is able to perform different movements that will culminate into normal visual perception and making sense of what is being seen. So that relates to the oculomotor skill, okay? And there are some standardized assessment that we want to use to do this. One of the basic ones that we often do is the confrontational assessment, whereby you want to judge if the patient can move in different direction, like perform upward lateral gaze, downward lateral gaze, or just lateral gaze alone. And all these it's very important. Maybe you are testing the function of your lateral rectus, your medial rectus, inferior obliques, superior obliques, all these muscles that work together to take the eyes into different direction. This is very important. Their function is very important, and the assessment is also essential to the assessment or remediating problem that has to do with visual processing. The next one is visual field. This is under the very base of the pyramid. The visual field, you're talking about how wide the eyes can see. So that's why when you are assessing a patient that you suspect to be having a neurological condition, you want to screen out, are they able to move the eyes in different directions? You want to look at least the 4 quadrants, okay, of the visual field to see if they can see properly perceive objects or stimuli in that direction. The next one is visual acuity. The visual acuity is actually talking about the clarity of the vision, while the visual field is talking about how wide they can see. The oculomotor skill is talking about how those muscles that I mentioned, lateral rectus, medial rectus, inferior oblique, superior oblique, how they work together in a conjugate manner to actually make sense of what is being seen. Next is visual attention. And the next, being able to kind of track down an object and attend to it and make sense of it. Next is scanning. Okay, you're able to kind of look through like a pool of images and make sense out of a particular object that is being focused on. Pattern recognition, visual memory, and visual cognition. Example of pattern recognition, if you see a shape of a square anywhere, irrespective of where, at what time you see it, you remain that this is a square, this is an oval shape, this is what a circular object. So being able to do that, the function, that component that makes us be able to do that has to do with pattern recognition. Visual memory, example of it is A very basic example of it is, for instance, you are copying a note on the board. No, somebody is writing on the board. You only look once, look up once, and by the time you read out what's in your mind, what is being written on the board, and you face your notebook without having to raise your head, and you're able to translate what you have visualized on the board into your notes. So visual memory is being displayed in that kind of task, and cognition, how you make sense of what is being seen. So now, how do we process this information? Either it is visual, either it is auditory, and all the information that come through our sense, different senses, sense of hearing, sense of vision, sense of tactile sense, and all that. Okay, how do we do that? So there are two major pathways that the brain engages in bringing out output from all the information that is being gotten from the environment. Okay, the stimuli, the information that is being received from the environment, that's at the level of reception. So it goes through the brain and it's channeled through two major pathways, such as the continuous and the automatic, and both of them will result into a specific output. So looking at the diagram, the incoming information, which is the reception, that shows how the information is being received and, being received and handled by the brain. It depicts, and the two funnel shape is talking about the pathway for processing the information. So reception, this is the initial stage where sensory information is being received, and it can either be filtered through the conscious pathway or the automatic pathway. The conscious pathway involves deliberate and effortful thought. It is used for a new or complex task, maybe that require attention or focus or learning, especially when it's happening for the first time. Automatic processing, again, that's for tasks that are well practiced. We've done them over and over again, and they become like a routine. So it requires little or no conscious effort and can be performed quickly, often without special consciousness or awareness. And both of them result into output. Both of them return. This is the final stage, representing the response of the action that results from the information that is being processed by the brain. Now, the way in which this information is processed can be affected as a result of neurological deficit, and that can result into the processing speed being slowed down. And most of all that have had interaction with stroke patients must have observed is that sometimes their response rate, maybe you are engaging them in discussion, in conversation, sometimes they may not be having maybe problem of a receptive aphasia. That is, they are not having problem with understanding what you're saying, but it's just because the rate at which the brain processes information is now being slowed down. So you see slowing of information processing speed, and this can be characterized as one of the most pronounced cognitive dysfunction associated with brain injury. You may see that in TBI, you may see it even in stroke as well. It may be the major cause of all cognitive and behavioral difficulties, and that is found after brain injury. Information processing is the foundation for perception, discrimination, matching, creation, and following sequence, categorization, and the ability to relate the information to previously learned information. So we see the importance of being able to process information at the normal speed, because difficulty in this area can signal and can affect our performance in different activities of our daily living and can affect our productivity as a whole. Now, looking at memory, which is at the last but one level of the highest level of the hierarchy. So memory relates to, it talks about ability to retain and recall information. So as we need to understand, I'm sure we already know that attention is very, very essential and key to our memory. So talking about memory, broadly speaking, we'll be looking at two types: the working memory, which we often refer to as short-term memory, and the long-term memory. Now, coming to the last stage, which is what? The executive function. So executive function relates to things like self-awareness, goal setting, self-initiation, planning and organization, self-regulation, which some refer to as self-ambition, self-monitoring and self-evaluation, and being able to be flexible and in our decision-making, our thought process pattern. So all these, they are elements of the cognitive function. Now, all of them together are what are any problem that affects any of them, all of them together will result into cognitive deficit, and which will definitely indicate or warrants a detailed and a very well-structured assessment. And that leads us to the next component of our presentation, which is assessment of cognition. Now, within the occupational therapy practice context or occupational therapy practice, the way we assess cognition, we assess cognition based on the standardized assessment and also the functional assessment. And the reason why we engage functional assessment is that standardized assessment sometimes can signal there is a problem, but the problem may not actually translate into functional deficit. For instance, a patient has caught like a patient has scored maybe on the standardized assessment, that's the Monterey Cognitive Assessment, MOCA assessment. The patient has scored, let's say, 26 is considered to be the normal least score an individual can have. But there have been instances where a patient can even score as low as 22. And yet, when you subject them to functional assessment, that is all the activities that defines their occupational profile, that is what they do on daily basis. When I say occupational profile, I'm not talking about their paid employment. In occupational therapy, occupational profile refers to all the activities that they have to carry out in their role. Role as in either their children, their husband, their friends, their teachers, anything they do. So any task they go through defines their role. That's what we refer to as what their occupational profile. So you may see that after doing standardized assessment, it does not lead to any visible deficit in their functional assessment. So, and it is function that the way the brain is built, the brain has an engram for function. That is, that's why when you wake up in the morning, once you pick your brush, you don't have to think and ask yourself, oh, here is brush in my hand. What do I do next? Automatically, the next thing is what? Automatically, you paste the brush and it goes into your mouth without having to sit down to say, okay, let me outline the steps to washing my teeth, because you've done it over and over again and the brain has actually built a pattern for you that whenever you grab a brush, the next thing that comes with it is what? Pasting the brush and brushing your teeth. So what am I trying to say? Standardized assessment is very, very important and very useful in all what we do in occupational therapy when we have to assess cognition. But in addition to that, we want to do functional assessment. So we subject them, we simulate the things that they are used to in their day-to-day life. So we may have to assess them in dressing. Let's take, for instance, an individual that has stroke, that is having apraxia, maybe having difficulty in understanding the concept. Okay, he has lost the concept of the fact that, oh, here is a long-sleeve sleeve, whereby my hand will have to go into the sleeve, okay? And the body will have to come over my body, okay? And in the front, I have to do the button. So you may see the person that has dressing apraxia trying to put the head, a stroke patient that has dressing apraxia, trying to put the head where the sleeve, where the hand should go to, because that concept is lost. You may give them, I've seen patients that attempted trying to brush the mouth with comb or trying to comb the hair with brush. These are problems that you can make out when you give them a very practical or day-to-day activities as their assessment. So, and it is that will tell you what they are going to struggle with or what is going to be the risk as far as safety is concerned when such a patient is discharged. So the need for functional assessment in occupational therapy cannot be overemphasized. And not just in occupational therapies, it's also good we have the knowledge of this as rehabilitation therapists. Now, coming to standardized assessment, the list is almost endless, but I've actually brought few examples. We've talked about the ATM that we discussed when we were discussing delirium. MOCA is another good standardized assessment that we often engage, and all these assessments, because their reliability, their objectivity, and their validity have been established with different researches. So it's been established that when they are used, they actually reflect the true states, or they give a good impression about the cognitive deficit that the patient may be having as part of the presentation of their neurological deficit. So now, having said that, let's look at the screening guidelines, cognition screening guidelines for stroke. We are using stroke as a representation of neurological deficit. So people with stroke should be considered to have at least some cognitive impairment in the early phase. as a matter of fact, for instance, in some practice contexts like the UK, whereby they rely much in their practice on NICE guideline, it is actually part of their guideline that any patient that presents with stroke must be screened for mood disorder, must be screened for what? For anxiety. So that's why oftentimes we engage the GAD-7 and the PHQ assessment just to screen for stroke. And by the time we see that they have some psychological deficits, that will lead to recommendation for other psychological intervention that will make their treatment be more holistic, not just concentrating on the physical deficit. So it is, and this is the line that WHO is also towing at the moment, that is not just enough to concentrate on the physical components, that they should be screened for cognition and mental health issue as well. And because they can impact their functional capability. So cognitive assessment should be conducted as part of comprehensive clinical assessment. In an ideal service, a brief screen such as MOCA will be undertaken in combination with a functional assessment by the occupational therapist. So this actually speaks to what I've explained in the previous slide. Now, looking at the standardized assessment, I've talked of Oxford Cognitive Screen, and these are standardized assessment, and the ACE, that's Anderbrook Cognitive Examination. These are standardized assessment that can be used, but some of them have sensitivity to certain deficits. For instance, OCF, the Oxford Cognitive Screen, is more patient friendly, unlike MOCA, okay, because there's a component of MOCA that has to do with verbal fluency, okay, but a patient, the question is, how do you apply that to a patient that is aphasic, either expressive or receptive? So OCF is more sensitive and more friendly, and when it comes to ACE2, it's designed to detect dementia and differentiate it from Alzheimer's dementia. You know, the word dementia is actually an umbrella term for over 100, close to 100 diagnoses, and one of them that you often see or that people use synonymously with it is Alzheimer's. So when you engage this assessment, it can give specific information that will help us to know that, oh, this is dementia and not Alzheimer's dementia, as is often, or frontal temporal dementia, because I'm sure we know there are different types of dementia, and these are just examples of them. So now, coming to MOCA, for want of time, I've actually brought MOCA forward. So this is how it looks like. There are different versions of it. There is 8.1 version, there's 8.2 version, there is 8.3 version, there's even what is called blind MOCA. But this is the one that appears to be more generic. It is score of 30, and it's got different components. It has a component of visuospatial, which is the executive function. It has a component of naming, a component of memory. Excuse me, please. Go to your room. Okay? It has a component of language. It has a component of abstraction. It has a component of a memory, which is the delay recall, and there's orientation aspect of it. And this aspect of a delay recall, the assessment we do under it is similar to a very brief mini mental scale examination. So now, depending on how the patient performs on this, we rate the patient level of cognitive deficit. As a matter of fact, when the least score is 26, so the least normal score, but objectively, in some contexts like maybe the UK, when the patient that is being assessed with this has low level of education, less than their secondary school equivalence in a Nigeria context, so the patient earns extra 1 point, and that is actually a due compensation for the fact that, okay, researches or it has been discovered that maybe higher level of education will enhance one performance. So for it not to be a complete disadvantage for those that have less than high school education. So once their level of education is less than high school, you had extra 1 point. So the first one, you just ask the patient, and it has a kind of a script for the instructions. So it's not something we just talk randomly about, because for it to be very objective, it has to be said, the script has to be read, the instruction has to be read the way the developer has actually scripted it. For instance, this first component, which speaks to visual spatial, the instruction reads, please draw a line in an ascending order, connecting a number to a letter, starting from you point to 1, then to A, then to 2, and it goes on and ends here. You point to E. The next instruction for the cube, please copy this drawing as accurately as you can. The next one will be, which is draw a clock. Please draw a clock, put in all the numbers, and set the time at 10 past 11. The next one will be the naming. Please name this animal. Tell me the name of this animal. You point to all those ones and they tell you the name. The next one is, oh, I'm going to read you some words now, which you have to remember now and later on. When I'm through, I will ask you to say them back to me exactly the way you've heard me read them. So you start face, velvet, church, daisy, red. So you give the patient the opportunity to repeat, to say this back to you. And after the patient must have said them back to you, either they said it correctly or they omitted some. You also say, I'm going to read you the same set of words for the second time. When I'm through, you read them back to me the same way you've heard me read them. It doesn't matter which other way you say them. So you now say it again, just like the way you said it before, and you expect the patient to say back to you. And by the time they say back to you, tell them, oh, I'm going to ask you at the end of the test. So you continue with other section. So it's only when you get to delayed recall that you now say, okay, at the beginning of the test, I read you some words. Can you tell me as many of those words you can remember now? So the patients will be expected to say them to you. So when they cannot say them to you, they cannot recall. So you go to the next level, which is what we call category Q. I've actually skipped some components, but I will come back to them just because this connects to the memory component. That's why I just went to the delayed recall. So the next thing is, okay, category Q. Now, when they are struggling, they cannot remember. You can, okay, the next instruction will be, okay, one of the words you are trying to remember, is it like human parts? So human parts should actually bring the memory if they still remember that, oh, actually it was face that was said. Now, if they got that, or if they didn't get that, you can move to the next level of clue, which is multiple choice. So you can now say, oh, if they still can't get that word, say, okay, I'm going to give you 3 options. One of them is the correct answer. So one of the words you are trying to remember is it shoulder, finger, face. So they pick one option which they think is correct, and based on what is correct, you mark them. Now, it is only when they are able to say it without prompt that you score them over this 5. So anything that, I mean, any word that is said, maybe as a result of category Q, maybe I tell you, oh, the word you are trying to remember, is it a type of building? Expecting them to say church. So if they say church, you score them for that. So now, the one that's the response that they make based on category Q. So for you to assess them objectively, so they get 2 points for each of the words that is said according to category Q. But if it's as a result of, I mean, after you have given them multiple choice that they give you the response, you score that 1 score for each correct answer. Okay, that is how you do the scoring of that subcomponent, because at the end, that delay recall, if you see it, it's a subsection on its own that can be scored on 15. So for instance, if the patient said face, after you ask them to record the word face, velvet, church, daisy, red, without any prompt. So each of these correct answer, you multiply by 3. For each correct answer is 3. So meaning having 5 words there means that, well, 3 times 5 is 15. So the subsection for that delay record, that means they got 15 over 15. But if it's based on category Q, each of the correct answers is scored 2. So you multiply the correct answer by a number of 2. If it's just only 2, that's 2 times 2, 4. 4 over 15 is what they had under the subsection of the delayed recall. Now, coming back to other section, you have the attention. The attention, I think, is very straightforward. So the attention component, you ask the patient, you say, I'm going to read you a set of numbers, which you have to tell me exactly the way you heard me read them out. So 2, 1, 8, 5, 4. So you pause, you expect them to say that. The next instruction will be, I'm going to read you another set of numbers, but when I'm through, you say them back to me in backward order. Say 7, 4, 2. So you expect them to say 2, 4, 7. And each correct response is 1, 1. Just like the preceding section, the visual spatial, each correct response is 1, 1, 1. The naming of the animal to each correct response is 1. And you can see that the total for that is 3 for animal naming, and for visual spatial, total is 5 because there are three different sections. But the drawing of clock is 3 things you are looking for. You want to look at, are they able to draw the contour of that clock? The contour, they can do it based on a circular shape or a kind of is it square or a rectangular shape. Each of them is allowed because there are some wall clock that are circular, there are some that are what? That are square, but the contour has to be well drawn. Again, you want to look at, are they able to put the numbers in it in a normal sequential order? Okay, that's 1 to 12. And the hands of the clock is the right, is the short hand pointing to where it ought to point to, because the instruction is set the time at 10 past 11. So you expect the short hand, you expect the long hand to be on 2 and expect the short hand to be on 11. So when they judge that correctly, that's when they have their full mark. Now coming to the going forward again, still under the attention, you've done the one with numbers. The next one is the assessment, still under attention. You read a sentence. Now I'm going to read you a set of random letters. Each time you read, you hear letter A, tap your finger once. So, and what you are just trying to say is how they are able to do what? To have focused attention, okay? Because they are just working, they are looking out for the time you are going to mention letter A. So you just start F, B, A, C, M, N, A, J, K, L. So each time they hear they hear letter A, they have to tap their finger once, and which shows that they caught it. So they are and for you to be able to judge them right as they are mentioning it, as getting it correctly, you keep striking them out. So for you to give them the full 1 mark here, that means there should just be what? 1 error. Is the maximum error that is allowed is what? That means what? With all the A's that you're going to read out, they are only permitted to not to get 1 correctly. So every other time they're expected to say it. So it's either 1 less or all the A's were actually gotten correctly. And the next one is serial 7 subtraction, which many of us we are familiar with. So you say, now I'm going to make you count from 100, okay, by subtracting. I'm going to make you count by subtracting 7 from 100. So you tell them that, and you say, are you ready? Once they say they are ready, they start with 93. You must affirm the first response. So when they say 93, say correct, so that they can continue, and you leave them to be saying that. Now, it's possible that after they say maybe 93, they made a mistake, but that mistake they made, if subsequent subtraction is consistent, that is, they keep, for instance, let me give an example. Maybe after they said 93, he now said 85. So you expect that the next number they are going to say should be what? 1 less than 79, as you can see in this list. So if they made a mistake and consistently they keep subtracting 7 in a way that is consistent from their error, you can still ignore that. So, and the scoring will be 4 to 5 points correct answers. We get what? The full 3 points. 3 correct subtraction will get 2 points, and 1 correct subtraction will get 1 point. So if they don't get anyone correctly, they get 0 for that. So this is how the scoring of that section is also done. The next one is in that language component. So you say, I'm going to read you a sentence now. Please repeat it after me exactly the way you will hear me read it out. So I only know that John is the one to help today. So you expect them to read them after you. And after they are done with that, I'm going to read you the second sentence, which you have to repeat after me. So you read the next one. The cat always hid under the couch when dogs were in the room. You just expect them to say that verbatim. And the next one is fluency. So this is what I actually made reference to when I was talking about comparing OCF with MOCA, that this verbal fluency A patient that is aphasic will not be able to do this. So, and how do you give instruction for this verbal fluency? So, okay, now I want you to tell me as many words as you can think of that begins with letter F. Please note that proper nouns, verbs, and numbers are not permitted. I will ask you to stop after 1 minute. So at this juncture, you bring out your stopwatch, you set it out for 60 seconds count, and when they are ready, you start. So what you expect them to do is how they're able to think, to generate words. Knowing, having those instructions in mind that they are not to use any form of verbs, any form of proper noun. Proper noun are just like names of person. It's easy for you to say, oh, Felicia, Faustina, Festus, and you just go on and on like that. And again, you can be playing with figure, be saying, oh, 5, 15, 14, okay, 55, 53, and all that. So all those ones will not be counted. And again, verbs. You can say fight, fighting, fought. You can just be swinging between present tense to past form of all those verbs. So all those ones will not be considered as depicting the normal fluency expected of that patient. And it is expected that the patient should be able to generate 11 of these words within 60 seconds. Okay, so once they are saying it, you keep writing them down because sometimes some of them may still say some words that are not permitted. But at the beginning, because not everybody may understand what proper nouns are, so you may make extra effort to ask them, do you know what proper nouns are? Do you know what are verbs? And you give them examples so that they know ab initio what will not be permitted or that will not count for their score. The next section on this is abstraction. Okay, this abstraction is their reasoning and their judgment, which is also a component of cognitive function and executive function. So you say, okay, I'm going to give you two words and you tell me to what category they belong to. For example, banana and orange, you expect them to say fruit, and you have to affirm their first response before you now go to the test. Now, once they say orange for banana, when they say fruit for orange and banana, you now go to a train and a bicycle. You expect them to say transport, a watch and a ruler. Is either they say measurement or measure. So these are the appropriate responses that will hand them the maximum 2 points. The next one is the delay recall, which I went to when we talked about memory. And the last component is the orientation. So you want to ask them the date, the month, the year, the day of the week, the place where they are, and the city where they are. Most of the time we see them in the hospital, so you expect them to mention the name of the hospital and the city or town which the hospital is located. So you, you score them over 30, and as I said, minimum score, normal score is 26. So any score that is below 26 is suggestive of cognitive impairment, and anyone that is lesser than 14 is a very severe cognitive impairment. So now, still talking about cognitive screen. Cognitive screen looks broadly at multiple domains, and I'm sure MOCA, as an example of the standard test, has actually laid out to rest. You could see different components. You saw visual spatial, you saw naming, memory, attention, language, abstraction, delay, recall, orientation to time, place, and person, and situation, and date and year. You saw that to also be part of the component. So cognitive screen is not a diagnostic tool, but and should only be used as part of the initial MDT assessment. So as we say, it's not for us to say, well, this patient has this condition, but you can use it to screen to tell you that there are what there are presentation that is suggestive of that problem and which can signal more specific assessment. Cognitive screen can be used to rule in cognitive problem and not rule it out. So it just to establish the fact that, oh, this patient has got stroke. And research has actually shown that the number of stroke patients will present with cognitive deficits. So for me not to be very sure of that assumption, let me engage cognitive assessment. So you can use it to rule in cognitive as deficit. Now, talking about the other part of the assessment, functional assessment. So, and as I said before, this functional assessment is what we do on daily basis that we will appraise and evaluate the patient performance is. For instance, I know this may be, strange to some of us that are not occupational therapists. How does making a cup of tea become an assessment? But actually, you can see different cognitive skills that are required to make a cup of tea, and even some physical component skill that are required to make a cup of tea. For instance, if you are working on the countertop in your kitchen, maybe you are making a cup of tea in the kitchen, your balance is very important. Your swelling tolerance, your strength, the strength of your upper extremities, because you are going to be doing a lot of functional reach. You are going to be doing a lot of hand function, like grasping the cup. You are going to be using the utensils to actually stir the tea. You make use of your prehensile grip and non-prehensile grip. You are going to be doing a lot of different hand movement. For instance, maybe you are adding sugar, either sugar. You are going to be engaging different kind of pinches. Your tip to tip may be used or your point to point. So all this tells you different component that is required just for that task of making a cup of tea. Now, looking at making a cup of tea, you don't just cup of tea, it's something that has to be done sequentially. If it's the water you want to pour into the cup first, but before you pour the water, definitely you have to, your reasoning and your judgment will tell you that definitely you have to pour in the water. And when you are boiling the water inside the kettle or using the hot, either your gas cooker, anything you're using, your safety awareness or safety judgment can also be assessed in that process. Okay. And what goes into the cup first? Is it the tea or the tea bag or your water or your sugar or your milk and all that? So there's a lot of planning and sequencing that is being brought to bear in making a cup of tea. Also, sensation is very required. For instance, somebody that is having sensory loss, that has a sensory registration deficit. If that person, in the course of pouring hot water from the kettle into the cup, if the water spills on him, he will not know, and he can suffer burns as a result of that. So sensation also can be tested. Okay. What about eye and hand coordination? You are using your hand to guide your hand to where the cup is, using your eye to guide your hand to where the spoon is, to where the tea bag is, to where the milk is. So eye and hand coordination is very necessary. What about concentration and attention span? What about spatial awareness? You need to be able to judge the where you are placing the kettle and the cup and the surface on which you are working with, placing those items in relation to the other so that it doesn't cause spillage on you to cause more injury. Memory, you need a lot of working memory, because, for instance, if you have been making tea before and you know the order in which you have always made it, so that working memory will definitely be required and be tested, required to be brought to bear when you are doing this task. What about processing, okay, or ability to follow instruction? Maybe you've been told in a particular way, maybe by the occupational therapist, okay, this is what you have to do first. Your ability to follow instruction, attention that is also required to complete the task is very, very, very important. So you could see just that task of making a cup of tea, see different cognitive element, physical element, and psychological element that is required to do that. And this is representative of all the activities we do on a daily basis. That's why one of the areas of expertise of occupational therapists is what we call activity analysis. And what is activity analysis? Activity analysis is what? Breaking down every task that we engage in into tasks and subtasks, and identifying the requirement. When we say the requirement, for every task we do, there is motor requirement, there is sensory requirement, there is space requirement, there is time requirement, there is cognitive requirement. So all the requirements all the tasks that we engage in has their different requirements. So if an individual is challenged in any of these requirements, definitely you can anticipate that the person will have problem in executing that task. So what I'm trying to say in essence is that every activity that are purposeful and meaningful to us can become a form of functional assessment for cognition. For instance, we do a lot of in other contexts. We don't do this in Nigeria because of our pattern of practice. So wash and dress assessment is an essential assessment that occupational therapists do to assess for cognition in neurological conditions or patients that have neurological deficit. So dressing, washing themselves, making a toast, even cooking session, all these things, because there's a lot of cognitive elements that are required. So, and that will definitely tell you what the patient is struggling with and give you the understanding of the strategy that you have to engage in remediating that deficit. Now, next is visual perception. So when we talk about visual perception, what exactly are we talking about? It is the brain ability to receive and interpret and act upon all the visual stimuli that the patient gather. It's the individual gather. It is the brain making sense of what the eye sees. And perceptual functions actually include awareness, recognition, discrimination, orientation, and the way we perceive images actually varies from person to person. So naturally speaking, our perception differs. So you now imagine how this is going to play out when there is a cognitive, when there is an underlying neurological deficit that has affected cognitive or visual perception. So now there are specific features or presentation of this perceptual function, visual perceptual function. And many of us, I'm sure we are familiar with some of them. There could be problem of visual or spatial neglect, which is very typical in stroke patient, whereby some of them you give them a test to read, you see that despite the fact that they are starting from the beginning, maybe the left side, they are unable to read to the hand on the right hand side. Even if you decide to fold the book, the text or the page into two again, just having to relate with half of it, the way they will still read it with just what they will still be able to read to hand, and can also result even in their dressing. Okay, they are not aware in the eating. This can play out whereby you serve them a plate of food, they just eat what half side of it, not having the awareness that the other section of the plate exists. Some of them you may see it play out maybe when they are shaving, they shave half side of the body. So these are some of the way that all these things can play out. And this may not be common in our context, but it's also one of the problems that we may see in patients with neurological deficit, which is called Charles-Bonnet syndrome. What is Charles-Bonnet syndrome? It's a form of visual hallucination, which is not the one you see in psychotic condition. For instance, when a patient is got schizophrenia, you expect them to have either auditory or visual hallucination with different content. But these individuals that are having this Charles-Bonnet syndrome is as a result of what? Visual problem. Maybe they are partially sighted, or they have a kind of partial loss of vision. So as a result of reduced visual information, visual stimulus to the visual information to the brain begin to generate a false image to compensate for that reduction in the visual information that is getting to the brain. And this will be playing out to the patient as if they are seeing what? They are seeing another object, which others are not seeing. So you see that patients with visual problem may have this visual hallucination, and it's actually more of cognition, because it is a problem of the brain generating another false image, and which they are responding to, and whoever is listening to them would perceive that as they are hallucinating. What about agnosia? Visual agnosia, you see, they find it difficult to recognize objects, to recognize pattern, to recognize things around them. What about this is color agnosia? This is specific to color. They may find it difficult to be able to differentiate color, and that's one of the things we do in our comprehensive neurological assessment, that we want to do color differentiation, because sometimes as basic as primary colors as some of the maybe stroke patient or patient with neurological deficit may find it difficult to be able to differentiate these colors from one another. What about orientation agnosia? For instance, no matter how I present a particular object, for instance, a pen, even if I make it to lie transverse or to face vertically, you will always notice this to be what? You always know it to be pen, irrespective of how it is being orientated, as they will say. So, but patients that have this problem, the moment you alter a particular orientation of object, they become confused. They may not be able to make out the image. What about prosopagnosia, that they have difficulty in recognizing faces? So that's why you may see them that their wives, their children, maybe they come visiting on admission, they will tell you they don't know them because that cognitive distortion has taken place, and they are finding it difficult to make sense of the familiar faces they have always known. What about form discrimination? This is one of the visual problem. under the visual discrimination problem that this patient may have. Depth perception and impairment. I want to speak to this because that depth perception and impairment it has a lot of risk. Every one of them has a lot of risk, but a very basic point is that you imagine a patient that is having difficulty in judging the depth of a seat. They will just bump into a chair and they may lose their balance. Coupled with the fact that this is a patient that has either hemiparesis or hemiplegia, that his balance, postural control, and alignment is actually is a problem. And having depth perception problem with it will definitely make them to be at higher risk. And this can play out in their what doing stairs. They may not be able to judge the depth of the steps, and they lose their balance, and that can result into other fatality. What about figure ground impairment? So this figure ground impairment speaks to being able to judge between the foreground and the background. For instance, if you keep a black purse or a black phone, okay, you keep it on a black sofa, a black leather chair, without so much struggle, you'll be able to make out, because the phone is the foreground, the chair or the table that is colored black that the phone is resting on, that's the background. So because we have our figure ground function to be intact, that's why we don't struggle. But for a patient, you may see them, maybe they are trying to undress, they're sitting on their bed or in the ward or at home. Maybe the bed has a white bedspread, and they are singlet, which is white color too, that is kept on that bed. They may sit beside it and be struggling. This is how all these things play out functionally, and that can lead to a lot of frustration that they find difficult locating things, and it may affect their independence in dressing and other parts of their activities of daily living. What about topographical orientation or disorientation? They may lose the mental geography of their or the layout of their environment, and oftentimes it may result into falls or may result into what getting lost, maybe when they go on the street. What about metamorphosia? So metamorphosia is talking about difficulty whereby the patient in this the object appears wrapped or bent. For instance, when they are seeing a straight line, what they will be interpreting to be maybe look like curve or wavy or slanted, and shape may be distorted. And this is going to kind of affect their judgment of objects around them, and can also impact greatly on their safety, because once the shape of an object is distorted, now the use of it becomes challenging to them, because what they have always known, maybe that object to be known for, okay, to them it's not appearing to be, and they may struggle in the use of basic items that contribute to their independence in activities of daily living. And the last but not the least is the palinopsia. The palinopsia is talking about persistence or reoccurrence of visual images after the object is gone. So in this case, you see, after an object is already taken out of their sight, they still have a kind of a meta imagery, or the picture is still, the object is still like appearing to be real to them. And you know what this can mean in terms of safety of this individual. You imagine an individual is driving and is having this problem. Maybe there are cars in front of him, maybe that has driven over another, but he's still seeing that car to be there, or those that have left before, they are still, or the one that are still there appears to have disappeared. So all this can affect their safety judgment and make them to be at risk of accident. And there can be other simpler examples of how all this deficit plays out. So this just goes to tell us that the cognitive problem or visual problem can actually complicate life or make the deficit or functional limitation in neurological condition to be very, very complex, and can even result into some fatalities that are more severe than their underlying pathology. So, we can trace some of these problems to different parts of the brain. For instance, the occipital lobe. So you have the patient having problem with discrimination of shape, size, and depth. Object agnosia and prosopagnosia are traceable to problem affecting the occipital lobe. And again, the right parietal lobe, when you see a patient that is having problem with form discrimination, topographical disorientation, spatial relation, and spatial neglect, or having visual agnosia, you can trace that to parietal lobe and other lobes of the brain like occipital parietal lobe. Spatial relation problem has been traced to that. Left parietal lobe associated agnosia like visual agnosia is also agnosia is traced to that. Temporal lobe, you see topographical orientation and other deficit that we can see on the screen to be traced to that. Now, how do we assess this perceptual problem? Okay, specifically in occupational therapy, we engage different activities. One of the peculiarities of occupational therapy is that our modality of treatment are always what are based on activities, things that we do on daily basis that are meaningful to us and that have that has specific or therapeutic purpose. So we can do some cancellation tasks, e.g., like canceling particular letters in a pool of letters, line by sections, the copying tasks, drawing tasks such as drawing a clock, as we saw in that MOCA assessment. And again, there's another scale we use to assess, which is a Catherine-Birch scale, which is a standardized tool for unilateral spatial neglect. And there are other tests like behavioral inattention tests and functional assessment and observation, which I talked about. So time will fail us to go into the specifics of this because I know our time is fast spent and we really taking so much time in trying to unpack some of these assessment and deficit. So intervention for visual perception, which is actually out of the scope of the, but since we've known about the deficits and just for a general knowledge from the point of view of occupational therapy, because some of them may not be completely, you may not be able to remediate them. So you may have to adopt some kind of compensatory strategy, educating the patient and the family for them to even have insight into the challenge they're having. And again, you may have to do environmental modification, taping the environment, making some environment more lit, or trying to provide a kind of contrast between the different texture, the foreground and the background, maybe from the test. For example, for a patient that is having depth perception problem, you may want to tape the edge of the step, maybe with a colorful tape, so that they are able to make the right judgment between the depth of the step and find it easy to navigate their ascending and descending the step. Scanning can be for treatment and also for assessment, and limb activation and spatial motor cueing. All these are some of the strategies. So lastly, what are the things we need to be aware of as far as cognitive deficit is concerned? It is important to clarify the baseline cognitive function. So what this is talking about is that, before the onset of stroke, it is very important that we know how functional has this person been, what is the level of the cognition of this individual, because stroke will only come to worsen what has been maybe once damaged. So we need to know so that we know what has come as a result, secondary to stroke or to neurological deficit, or what has always been the problem. Again, the environment of the person is very key to how these problems play out. And again, assessment of the hearing, of the visual function, like sight of the person, and the medical stability of the person at the point of assessment, they are key to our assessment. Okay, just as the hearing, the visual, the vision of the person. Again, the mood of the person is very important because mood can affect cognition and therefore can impact on observed behavior and screen outcomes. So everyone's observation of behavior are important, including patient's own report. So what we are trying to say is that, looking at the screening that we do for assessment, for anxiety and depression, we are asking them about their feelings. So it's to a large extent their own report, their own judgment of their feeling is very key in leading us to the impression or the assessment we make out of them. So that's why they also we have to give credence to the fact that they are also part of the assessment process. And this also aligns and resonates with a client-centered approach to treatment or assessment of patient. And functional assessment is also very essential in addition to all the standardized assessment, because as I said before, it is the functional assessment that will reveal the functional deficit that the individual is struggling with. So in conclusion, the assessment of cognition and mental problems after neurological condition is crucial for optimizing patient recovery and improving long-term outcomes. Early and comprehensive evaluation can identify cognitive impairment and mental health issues, and which will enable targeted intervention and support. By prioritizing this assessment, healthcare professionals, rehabilitation professionals can enhance quality of life of their patients with neurological conditions and facilitate their reintegration into the community, into their daily life activities. Thank you for listening to me. This is the end of our presentation.
Okay.
Hold on. Hello? These are the references. Hello? Hello? Hello?
Hello, can everyone hear me, please?
Please, can you hear me?
Yeah, I can hear you, sir. Can you all hear
Well,
me?
I was wondering if I was actually muted all this long.
Okay, I
Because
think.
I didn't get any response. So,
Oh,
where's
sorry, sir. I've been trying to speak. I think it was from my hand. All
okay?
right, thank you so much, sir. So I would say this is actually a very comprehensive class, and I noticed that you are kind of rushing, so you meet up with time. Yeah, but thank you so much, sir, if, um, for this exclusive class and teaching on this. Okay, sorry. So I'll permit you to unmute. I don't know if you have any question, although time is no longer on our side, but if you can just summarize your question, then it will be quick for you to answer. So please, if you have any question, kindly wave. Just raise your hand if you have any question. Dr. Grace, do you have any question, ma? Okay, ma, let me unmute you. You can unmute your mic now, ma.
Good evening, sir. Good evening, everyone.
Good evening,
Thank you very much for the beautiful presentation. I'm quite very detailed and easy to understand. But when you were talking about the MOCA assessment, sir,
yes.
I'm looking at the non-literate patients. How do you adapt it? Is it the non-literate patients that are not literate?
Okay.
Yeah,
Yes.
so how do you, is it allowed to adapt it to you? And then most patients with stroke, for example, they kind of go default back to their dialect. Most of them, even though they are educated, they kind of fall back to speaking their dialect as compared to English.
Yes, they lose the language, right?
Yeah, so how do we place them when doing the assessment? And when you're looking at the functional assessment and using T as a reference, in our context, culturally, we're looking at PAP. And then when you even look at the male-female cultural upbringing, you find out that most males don't cook. The wives cook for them. So how do you place male patients asking them those questions when some of them, they've never been in the kitchen, they've always been served by their wives. So how do we differentiate this assessment for our own cultural background? So in essence, I'm looking at culturally biased elements in the assessment tools that you referenced, sir. Thank you very much.
All right. So thank you for the question. To be candid, it's actually a challenge for non-literate patients. And for instance, it's not just only the loss of maybe the language as we see, a good number of them may become aphasic, either expressive or receptive in understanding the spoken language. So that's why OCF, the Oxford Cognitive Screen, which has to do with just demonstration, can be used in place of MOCA. And the essential component of MOCA, they are also covered in OCF. So it's actually more comprehensive because it accommodates me some of these deficits that may be limited by MOCA. So OCF may be an option, okay? And some of the things is just no matter how illiterate one may be, I don't think once you can see, okay, you can demonstrate. Okay, for instance, like hand movements, your hand coming to your face or to your head and making some kind of gestures and asking the patient to demonstrate that. Okay, is some component of the OCF that can make it more friendly to a patient that may not be expressive or having issue with language. Now, coming to the functional assessment, a cup of tea, is represented. It's not actually. We are not. It's not part of our culture, as we all know. But I only use that as an example. The bottom line is functional assessment. A patient that cannot make cup of tea, that cannot even maybe make pap for himself. Everybody dresses independently. I don't think we don't have to go to school to know how to wear our clothes. We don't have to go to school to know how to what to wash ourselves in the bathroom. So, and that one of the functional assessment that I talk about is washing and dressing. And for you to be able to do this, it may take the expertise of an occupational therapist. The reason being that we do a lot of activity analysis for that dressing. Now, what do we mean by activity analysis? What are the materials that are required? Okay, what is the physical component in terms of the range of motion that the patient will need? For instance, if a patient is having shoulder subluxation, okay, the patient may not be able to independently tuck that hand into a particular sleeve. A patient that is having stiff joints, okay, as a result of maybe spasticity of the muscle tone, may not be able to have the normal voluntary control of the hand to put it into the sleeve. So these are some of the things that we can we can see in addition to being able to understand the concept of, oh, this is where I have to put my hand, this is where I have to put my leg, this is how I have to do the botany. Because in dressing, you are looking at the planning of the planning skill, you are looking at the sequencing skill, you are looking at the patient understanding concept, because some of them may be having dressing apraxia. They may not be able to know where they tuck the hand into another, putting head where the sleeve have to go to. Dressing may even be too complex. Even what about brushing of teeth? Brushing of teeth has some sub-tasks with it. Getting your brush, putting paste on it. These are the sequence. And you want to, those that usually damp their brushes before they brush their teeth, you want to see that. And what is the placement? How are they using it? I've seen a patient that's attempted using the comb to brush, the brush to comb the hair. And that is crystal clear that that patient has apraxia. So it's not just limited to making of meal. So any activity that the patient premorbidly is used to can be used as a form of assessment. Once you understand, you have done your activity configuration, activity analysis, and you know the cognitive element that is involved in that task and that you want to use that task to assess, that can be a good assessment. I don't know if I've answered your question, man. So it's not just limited to cup of tea. So
Wow. Thank you so much, sir.
all right.
Thank you, thank you, thank you. So, do you have any other question? I can't see any wave here. So I assume that all the questions we have for our speaker for tonight. So please, can we appreciate our speaker before? Okay. Someone raised his hand. Is that Solomon? Pete Solomon, you can speak now.
Hello, good evening.
Good evening, sir. We can hear you. Go ahead.
Thank you so much to the presenter. I know time is going, but if you can go through the chat, there are some questions I posted over there. Maybe I can give a recap. I was just wondering how occupational therapists, I'm a P&O professional, and I was just wondering how
Okay.
occupational therapists can be of assistance to a patient of ours whose sole problem is limb amputation. How can they adapt? Is there anything that we need to know on how to make them adapt to their environment using their P&O devices? Because from the
Oh,
lectures you have given, it appears there was quite some areas you talked about, like the sensory areas, deficiencies, and all that. But I'm mainly specifically looking at an individual whose sole issue is limb amputation. How can they adapt to their environment?
okay.
Thank you. Yeah.
Thank you, sir. From your experience as P&O expert, so it depends on particularly what problem the patient is presenting with. Because if you are looking at when you talk about limb amputation, as we know, there could be different problem. Maybe are you talking about problem of phantom limb sensation or the sensory loss that the patient is having that is of concern to you, or just because that part is missing, the patient's functional independence is compromised. And again, what level, I mean, which part of amputation are we talking about? Are you talking about upper extremity amputation? And even if the upper extremity, what level of the limb is being amputated? Because all these will definitely determine what we can do. But since the question came in a very generic way, I will also answer in a generic way. Now, what occupational therapists can do if it's a problem of sensory, there are some different intervention about sensory re-education that we can do to facilitate the sensation of the patient, providing them with different sensory stimuli, texture, and trying to regulate their response and thereby enhancing their responses to that. Again, occupational therapists in terms of providing them, teaching them compensatory method of getting about the activities of daily living with respect to dressing, with respect to feeding, with respect to maybe toilet transfer, with respect to bed transfer, with respect to maybe transferring from chair to bed or chair to. So it depends on what the functional deficit that the patient is presenting with. Another thing occupational therapists can do is to modify their environment. You know, one of the things that occupational therapists has good expertise in is this concept of adapting the environment, or basically, specifically speaking, ergonomics, adapting the
Yeah.
person to his functional task or adapting the task to the person. So, and this comes to what I said earlier on, having a good understanding of the occupational profile of the patient. What is his role? Okay, what does he have to do? What is his routine? What are the things he has to do on daily basis? And all this will determine the kind of compensatory strategies or adaptive program that will put in place that will make the person to be able to bypass the underlying functional deficit that the patient is having. So all what I've talked about, they are just like theme of intervention that has some specifics in them that time will fail us to unpack in details. I don't know if I've touched on some of the things that OT can do for this patient. So that's what I
O-
will say for now. Yes.
Okay. All right. Thanks so much, sir. Does no one raised his hand, so I think he has
Yeah.
something more to say.
No, thank you so much for the information. Yeah. My question was a bit generic because some of the challenges we are facing, because we don't have so many occupational therapists. Where I learned, we have a few of them, and I know there is a lot of job they can do, especially like adaptation in the houses. How do they make use of their devices within their environment? I think everything boils down on let's keep praying. We have so many occupational therapists. Like in my center now in Enugu, we only work with the physiotherapists, but I know that occupational therapists have a very big role to play if we are to talk about holistic rehabilitation plan for a
Yeah.
patient with a limb amputation. Thank you so much for your answer and for the presentation. Thank you so much.
Okay, thank you, sir, for the question. Sir, we have a question on the chat. Let me read it out. It says, "Does stroke survivor and survivors regain full cognitive function before reintegration into the society?"
Now, is that the question, or you're still reading the
It's a
continuation?
question, sir.
Yes. Now, so the answer to that question will not come as yes and will not come as no, because there is a lot of factors that determines what level of recovery that individual attains. after stroke or any other form of a neurological deficit. Number one, if you look at that brain pathology that I presented at the beginning, you will see the premorbid personality or the coping lifestyle of the person can, in a way, influence what level of cognitive recovery the person has. And there's something we call there's a concept of cognitive reserve that we all have. How we've been able to train or the level of cognition level that we've been able to develop premorbidly can also go a long way to determine the level of functional recovery that we have after cognitive deficit. And again, the severity of the condition too, because when we talk about stroke is actually, to a large extent, is generic. There are different vessels that are affected, there are different lobes, there are different sectors in the brain that can be affected. So all this will play will play a big role in determining what the 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 recovery is. And again, another factor is at what stage is this patient being presented for rehabilitation. And one thing that experience had actually shown in our context is that most of our stroke patients, they have late presentation. And not only that, the other pharmacological intervention that the patient is also receiving can play a lot of factors. I don't know if I'm following what I'm trying to say. So that's why it may be very difficult to say a stroke patient after rehabilitation for cognition will attain 100% recovery. But the beauty of occupational therapy is that we believe that in every disability there's an ability, because in occupational therapy we have two perspectives to rehabilitation. On the one hand, we have what is called remediation. On the other hand, what is called adaptation. Remediation will be geared towards trying to improve the what we call performance component. For instance, the sensory laws, the motor laws, the perceptual laws, the cognitive laws that the person has. Okay, maybe you are working on improving the attention span in terms of cognitive deficit now, improving the processing ability to follow. So there are some specific activities that can be given, or they may come in form of games, they may come in form of daily life activities that the person will be engaged in, which is geared towards improving all those components, all those elements of them. But as that is going on, we can also engage the adaptive, which is part of them could be what compensatory method. For instance, a patient that is having a problem with memory, okay, you may have to teach the person on how to, for instance, maybe the memory is affecting him not to be able to take his medication, the right dosage at time. You may get a kind of pill organizer, a dosage box that can help them to do that. A patient that is forgetting things, teach them the use, train them in the use of diary, use of a timer or alarm system to prompt them to do certain things. Do you understand? Or having their home design label, maybe those that will having problem of topographical orientation, that maybe from their dining they miss their way, they can't get to toilet independently without missing their way another. There are some symbols, I'm sure you must have seen it in public places, that you put on the toilet that signals, oh, this is toilet. There are some symbols that you can, in picture form, that you can put in the area that is designated as the dining site or bedroom. So these are some of the adaptive strategies that we can engage while we are working on the remediation of the component deficit that the person has. We are also engaging the person on all these compensatory strategies so that all what we are trying to promote is functional independence. Despite the underlying deficit, the patient is able to do things for himself within the limit of his disability. So these two approaches are usually combined when we are remediating our patient, either for cognitive deficit or for physical component deficit. So this is what we do for them, but I can't tell you that a particular patient will have total recovery. But one thing that is sure is that they usually have some level of recovery in terms of functional recovery or improvement in their functional performance.
Okay. I thank you so much, sir. Thank you so much. Please, can we appreciate our guest for tonight's our facilitator? Can we say thank you? Thank you so much, sir, for your time and well-detailed presentation. Really appreciate, sir. All right, so everyone,
Thank you
we
for having
have
me.
a quiz. As usual, the link has been sent to the chat. please do well to copy it and then respond to the questions later on after this class. It will be sent to the WhatsApp group. So check your chats right now, and yes, click on the link, save it, and then answer to the question later. So thank you for coming to the class
Thank you
today.
for having me.
Thank you so much, sir. And thank you so much, everyone, for being around. Thank you for your questions too. It helped us to know and learn better. All right. Thanks so much, everyone. Have a good night's rest.
Have a good night too. Bye.
Night, sir.